Chapter 8 is pretty much the bread and butter of everything that we will learn from now on out. Okay. We're going to go over cellular metabolism and components necessary for adequate confusion. EMTs Patty and Gus are on the scene of a 52-year-old male who is complaining of difficulty breathing. The patient is breathing shallowly and rapidly. He gasps, "Need help, can't breathe." Alright, so what purpose does breathing actually serve?
Getting oxygen into your bloodstream.
Okay, getting oxygen to your bloodstream. What else? Oxygen goes in, what goes out?
Carbon dioxide.
Okay, what else?
Nitrogen.
No. Waste products. Okay. In what ways does a problem with breathing affect the body? Does it hinder it or help it?
A problem with breathing hinders.
Okay. Problem with breathing hinders. Alright. One of the most fundamental purposes of emergency care is maintaining adequate perfusion of body cells to ensure continuous delivery of oxygen, glucose, and removal of waste byproducts. These basic molecules, which is oxygen and glucose, are necessary for normal cell metabolism and function. Alright, cellular metabolism is also known as cellular respiration. It is the process in which the body breaks down molecules of glucose to produce energy for the body. There are two types. Anybody know those two types? Okay, you have
Aerobic and anaerobic.
aerobic and anaerobic. One means with oxygen, one means without oxygen. Aerobic metabolism is the breakdown of molecules such as glucose through a series of reactions that produce energy within the cell. This happens in the presence of oxygen. Okay. This is kind of like what it looks like. Oxygen goes in, it creates a chemical reaction, glucose is released, and ATP, which is your energy, is produced. Cells must engage in metabolism to produce the energy needed by the cell to carry out its function. When there is an adequate amount of oxygen available to the cell, it produces a greater amount of energy, and the body is able to convert waste products to forms that the body can then eliminate. Okay. Mitochondria is the what of the cell? Powerhouse. Everybody remembers that from 7th grade biology. Other byproducts of aerobic metabolism include heat, carbon dioxide, and water. The heat produced is to maintain a normal body core temperature. As you would expect, an increased metabolism results in increased body core temperature. The carbon dioxide produced by metabolism is transported in the blood and blown off in the exhalation process of normal respiration. An increase in metabolism results in an increase in the respiratory rate to eliminate the extra carbon dioxide. The water produced by metabolism is reabsorbed and used within the body or excreted. All of the products of aerobic metabolism are either used by the body or eliminated without causing any harm to the cells or the patient, and a high amount of energy is made available to allow for normal body functions. Alright, sodium is primarily found outside the cell. Potassium is primarily found inside the cell. You have what's called a sodium-potassium pump. Without a functioning sodium-potassium pump, sodium that finds its way into the cell cannot exit and accumulates there. Okay? Energy, which is ATP, is required to pump sodium molecules out of the cell against a concentration gradient. Potassium then moves in with the gradient to flow into the cell. Sodium and potassium are exchanged in a continuous cycle that is necessary for proper cell function. The cycle continues as long as the cell produces energy throughout aerobic metabolism. when insufficient energy is produced through anaerobic metabolism, the sodium-potassium pump will fail and the cell is gonna what? It's gonna die, okay? When the concentration of sodium in the cell is too high, potassium cannot enter in either, and the cell cannot function. Excess sodium in the cell allows excess water to enter the cell because water follows what? Sodium. Water always follows sodium. Okay? Excess water causes the cell to swell, rupture, and then die. Okay? So we have to have this functioning pump. We'll just talk about that. Anaerobic metabolism is the breakdown of molecules in the cell without the presence of oxygen. Just as with aerobic metabolism, glucose crosses the cell membrane, and normal glycolysis occurs with the production of pyruvic acid and the release of a small amount of ATP. Without the availability of oxygen, the pyruvic acid is not able to enter the next phase of metabolism and is converted into lactic acid. You know, when you go to the gym and it's like your first day and you work out really, really hard, and the next day your muscles are sore, that's lactic acid buildup, okay? So the byproduct of anaerobic metabolism are lactic acid and a very small amount of ATP. All right. We've already talked about all this. If the acid accumulates, it produces an acidic environment that may disturb its function and stability. High acid levels inactivate enzyme function, disrupt cell membranes, and ultimately leads to the cell's death. In addition, the cell has very little energy to perform its normal function. Perfusion can be described as the delivery of oxygen, glucose, and other substances to the cell, and the elimination of waste products from the cell. To maintain adequate perfusion, the components of the delivery and removal system must work properly. All right, here's your components. You have the composition of ambient air. How much oxygen is actually in ambient air? 21%. All right, you have to have a patent airway. If you have a airway obstruction, are you going to be getting that ambient air? No. Okay. Then you have mechanics of ventilation. All right. If your lungs are not working properly, are they enlarging and expanding to allow the oxygen to come in? Okay. They're probably not going to allow the oxygen to move out. Then you have what's called a ventilation to perfusion ratio. Okay. This means, are you taking enough of that ambient oxygen in, and do you have enough perfusion to absorb that oxygen? Where's the oxygen molecule on the blood cell? Where does it attach on the red blood cell? It attaches to the hemoglobin. Okay? If you don't have enough blood going through the capillaries where that cellular metabolism takes place between the capillaries and the alveoli, then you do not have a good ventilation to perfusion ratio. Okay? And this can happen because of blood loss. Alright? And you have to have the goods to transport the oxygen and the carbon dioxide. Okay? If you have misshaped blood cells, you do not transport oxygen and carbon dioxide like everybody else. Alright, also have to have blood volume, like we talked about before. The pump function of the heart. The heart's not pumping, that oxygen in that blood ain't going nowhere, right? You have to have systemic vascular resistance, okay? You have to have that microcirculation in the capillaries, and you have to have a blood pressure. Alright, cell death equals tissue death, or cell death leads to tissue death. Tissue death leads to organ death. Organ death leads to organ system death, and that leads to organism death. Okay? Everything we do starts at the cellular level. All right, Gus quickly moves to the next patient to better assess his condition while Patty unzips the airway kit and begins to select equipment to begin patient care. What specifically will Gus be assessing to determine the patient's condition?
The airway.
All right, airway. What about his pulse?
Pulse, blood pressure.
Okay. What about just the
I
pulse?
guess you need to figure out what happened first. Like, is it, did you get, you know?
Does that really matter on the cellular level?
Well, I guess I don't say.
Okay. I mean, it's good to know, but however, what exactly happened? Did somebody have a car wreck, or did they run over their foot with a lawnmower? Like you're losing blood somewhere, and at the cellular level, it doesn't really matter. That blood's not circulating. You see what I'm saying? All right. So if I have, you said blood pressure. That's not a wrong idea, but I'm going to teach you how to know what their blood pressure is just by looking at your patient and checking their pulse. Okay. If you look at that patient, they are pale, they are cyanotic, they are sweaty, they do not have a radial pulse. Right, do you think their blood pressure is going to be great?
No.
Okay. So, blood pressure, we didn't even take the blood pressure cuff out. Okay? We can look at that patient, we can touch that patient with 2 fingers and figure out what their blood pressure is
Have at least a 60 with carotid, right?
with a carotid. But if you don't have one at the radial, it's at least less than what?
90.
90. Okay? Anything less than 90 is considered hypotensive. Okay? So, exactly what is happening to this patient on the cellular level? They're probably not perfusing. They're not getting ventilations. They're not having that cellular respiration that everybody has to have. So what do you think is going to happen if they don't intervene quickly or appropriately? I'm going to throw that word in there, appropriately.
Cells are gonna start dying.
Okay? And that's going to lead to what?
Organ tissue failure.
Okay? Which leads to what?
Organ failure.
Which leads to what? Death.
Organism failure.
Which is
Death.
death. Okay? This whole body that we have, all the systems, that is one big gigantic organism. Okay? And it's kind of like a cascade. Alright? And the further you let it go, the harder it is to catch up. Alright? Does that make sense? Okay. Alright, components of ambient air. The concentration of oxygen in ambient air is what? 21%. Okay? Contains 79% nitrogen and trace amounts of argon and carbon dioxide. Okay? And there's your little slide about it. Alright, increasing the concentration of oxygen in breathed air increases the number of oxygen molecules in the alveoli, the blood, and the cells. Okay? If we're getting 21% just standing up, talking to each other, and you slap a non-rebreather on somebody, that's straight pure oxygen. They're going to be getting 100%. Alright? So that's going to be a lot more than just 21%. Okay? The more oxygen they can get in, the more we can feed the cells. Okay? Now, there is an adverse to that. In some cases, oxygen is actually a bad thing. It releases free radicals and can actually cause more damage than what you intend. Okay? It's also a vasoconstrictor. Alright, So, one way to improve cellular oxygenation is by increasing the concentration of oxygen in the air breathed in by the patient. All right, some toxic gases displace the amount of oxygen in the air, which actually suffocates the patient. What do you think that is? Anybody know?
Carbon dioxide.
Carbon dioxide. Carbon dioxide has a 4 times greater affinity to bind to the hemoglobin than oxygen does. Okay? So if you go to a house fire or somebody that's been sitting in the car trying to commit suicide and you stick that cold socks on them, all right, and it's going to say 100% because those hemoglobin molecules are bound with something. Okay? It might not necessarily be oxygen, but it's bound with carbon dioxide, and it will actually give you a false positive reading. All right? It'll give you a false number. Cyanide is also another one that interferes with oxygen. One of the most basic and important aspects of emergency care is to provide, maintain, and establish a patent airway. A patent airway is one that is open, is not obstructed by blood, secretions, vomitus, tissue, bone, teeth, or any other substance. Establishing an open and patent airway is typically one of the first steps in emergency care. In some cases, it may be the only care necessary to treat the patient in the pre-hospital setting. So, failure to recognize this or establish and maintain a patent airway can lead to death. I mean, that's just point blank, clear as it can be. An obstruction can occur anywhere in those locations. The nasopharynx, which is the portion of the airway from the nostrils to the soft palate, can be occluded by blood, secretions, vomit, tissue swelling, bone fragments, or other substances. This usually does not pose a major risk because of the oropharynx. All right, the oropharynx remains clear, then the nasopharynx you can breathe through your mouth. Okay. The oropharynx, the portion of the airway from the mouth and the soft palate to the epiglottis, can also become obstructed by the tongue. The tongue is the most common airway obstruction. Foreign bodies, tissue swelling, hematomas, blood, vomit, and other substances. Any obstruction must be removed immediately. All right, what's that little hangy downy thing in the back of your that covers your trachea? What's that thing called? No, covers your trachea. The uvula is the little hangy downy thing in the back of your throat. This covers your trachea.
Is it a leaf shape?
Yup.
It's the epiglottis.
Epiglottis. All right. Epiglottis is a flap of cartilaginous tissue that covers the opening of the larynx during swallowing. If the epiglottis is injured or swells or becomes inflamed from infection called epiglottitis, it can include the airway at the level of the larynx. If you have somebody with epiglottitis, they will be drooling, they will tell you they do not want to swallow, usually have a fever, that sort of thing, because it's an infection. Do not put anything in their mouth. If it's a kid, usually you'll have this with kids. If it's a kid, you want to do blow-by oxygen for them, okay? Do anything you can do to keep them calm, all right? Because one spasm of that epiglottis, and it's all over with, all right? There's nothing, I mean, we can crack them and stuff, but I would prefer not to do that with a needle and stuff in the back of the truck. But there's literally nothing at a basic level you can do. The larynx can be obstructed by laryngospasm, also called a laryngeal spasm, where the vocal cords spasm together and close. This prevents air from passing through the trachea. This may result from injury, insertion of mechanical airways, or administration of some medications. A fracture to the larynx causes the laryngeal structures to lose stability and move inward and downward, creating an obstruction. Okay, it only takes 30 pounds of pressure to crush your larynx. You see these people that drive down the interstate and they got their seatbelt across their neck? Yeah. If they have a wreck, they're going to crush their larynx. All right. Something else I was going to say about that. I forgot now. Obstruction of the trachea and bronchi by secretions. You're going to see this with CHF, COPD, asthma patients. All right, blood, vomitus, food particles, objects, tissue swelling, bone, or other substances can block the airflow, which supplies the alveoli and air sacs of the lungs with oxygenated air. All right, we've already talked about that. All right, what exactly is ventilation? Is ventilation and respiration the same thing? I just had this talk with the medic students. Ventilation and respiration are not the same thing, okay? Ventilation is a mechanical process that relies on changes in pressure inside the thorax to move air in and out of the lungs. This is called what?
Autonomosity, I believe.
Huh?
Is it autonomosity?
No. What kind of pressure is it inside the chest? Huh?
It's a negative?
It's a negative pressure. Okay? The alterations in the pressure occur because of changes to the size of the thorax. Ventilation conforms to Boyle's law, which states that the volume of gas is inversely proportionate to the pressure. It can be quickly summarized as an increase in pressure, more positive, decreases the volume of gas. A decrease in pressure, more negative, increases the volume of gas. As the parietal pleural lining is pulled upward and outward with the expansion of the chest wall, the serous fluid between the two linings also pulls the viscera lining upward and outward. This is sometimes called a water glass effect. It's kind of similar to the surface tension created by moisture between the bottom of a glass and the surface of the glass is sitting on, which tends to lift the surface of the glass, or tends to lift the glass off the surface. The visceral lining is attached to the outer surface of the lung. Therefore, when the visceral lining is pulled outward, the lung is forced to expand. The natural tendency of the lung, however, is to recoil and collapse because of the elasticity of the tissue. This causes the lungs to constantly pull inwards as the thoracic cage is pulling it outwards. This opposing pull creates a constant negative pressure or a vacuum in the pleural space. We got a pump with the heart and we got a vacuum in the lungs. Use of accessory muscles. What are your accessory muscles? What? Say it.
Around your neck.
Okay. Where else?
It's your abdomen and chest.
Right. All right. Use of accessory muscles may be required either to help increase the chest size or to draw more lungs into the chest and draw more air into the chest and lungs, or to help decrease the chest size to force air out of the lungs and chest. Contracting the accessory muscles uses way more energy than normal. Okay, this is not something we use on a normal basis. Okay, keep in mind that adequate amounts of oxygen must be constantly delivered to the cells to produce energy. A patient who needs to use accessory muscles to inhale may already be experiencing a lack of oxygen delivery and energy production. If the patient lacks the energy needed to contract both regular and their accessory muscles of inhalation, the respiratory muscles will begin to fail. This will result in inadequate ventilation, which will compound the patient's problem even further, which decreases the oxygen delivery to the cells. All right, these are your accessory muscles. You have your sternocleidomastoid muscles your scalene muscles, and your pectoralis minor muscles. That's a mouthful. You also have in abdominal muscles and internal intercostal muscles. All right, compliance is a measure of the ability of the chest wall and lungs to stretch, distend, and expand. A condition that causes the lungs or the chest wall to become stiff, which decreases compliance. And decreasing compliance makes it more difficult for the patient to move air in and out of the lungs. It also makes it more difficult for you to ventilate the patient artificially. Airway resistance is related to the ease of airflow down the conduit of the airway structures leading to the alveoli. What are the conduit of airway structures? The trachea, bronchioles.
Larynx.
Okay. All right.
Bronco.
A higher airway resistance makes it more difficult to move air through these airways. A lower resistance makes it easier. A higher airway resistance requires the patient to work harder to breathe, expending more energy and possibly using accessory muscles, which may accelerate respiratory muscle fatigue and failure. The most common cause of increased airway resistance is edema, or what? What does edema mean? Swelling. All right. Mucus and constriction of the bronchioles will also decrease the radius of the airway and resistance. Okay. Asthma comes to mind there, the mucus and the constriction of the bronchioles. Pleural space. The potential space between the pleura maintains a negative pressure. If a break occurs in the continuity of either the parietal pleura from an open wound to the thorax or the visceral pleura from an injury to the lung tissue, the negative pressure draws air into the pleural space. With each inhalation, the thorax increases its size and the pleural pressure becomes more negative. This draws even more air into the pleural space, increasing its volume and collapsing the lung. That's why we talked about a penetrating injury to the chest. You always want to put that occlusive dressing on there. All right. Lung collapse severely interferes with the ability of the alveoli to fill with air and create an interface with the pulmonary capillaries, which reduces gas exchange with the blood and leads to what? Hypoxia. Therefore, including any open wound to the chest is done early in the primary assessment of a patient. Okay? Keep that in mind, especially when we get to assessments and stuff. Minute volume, also known as minute ventilation. It's the amount of air moved in and out of the lung in 1 minute. It's determined by multiplying the tidal volume by the frequency of ventilation in 1 minute. The tidal volume is the volume of air breathed in with each individual breath. Did you not just see him do that? Like,
I know.
the frequency of volume is generally calculated as the number of ventilations in 1 minute. The formula for this is minute ventilation equals tidal volume times frequency of ventilation. With a tidal volume of 200 milliliters and a ventilatory rate of 28 breaths per minute, it appears as if the minute ventilation is near the normal of 6,000 milliliters or 6 liters per minute. However, even though the minute ventilation appears to be almost normal in this patient example, severe hypoxia may still occur because of the small amount of air actually getting to the alveoli for gas exchange. Increasing the frequency of ventilation may improve the amount of air in and out of the respiratory tract in 1 minute. However, if the tidal volume is too low, an adequate amount of air may never make it completely down to the alveoli where gas exchange takes place. Okay? Alveolar ventilation is the amount of air moved in and out of the alveoli in 1 minute. The key in this definition is specifically the amount of air moving in and out of the alveoli. Unlike minute volume, where the calculation is concerned only with air movement in and out of the lungs and the respiratory tract. Alveolar ventilation is related to the concept of anatomical dead airspace. Dead airspace consists of anatomic areas in the respiratory tract where air collects during inhalation. This is areas where no gas exchange occurs. Okay? A reduction in tidal volume may dramatically reduce the alveolar ventilation even when the patient increases their frequency of ventilations to compensate. Hypoxia. You can get this from low tidal volume, slow ventilatory rate, fast ventilatory rate. Okay? A low tidal volume decreases the alveolar ventilation by not putting enough air into the alveoli with each breath. Not enough air goes in, it doesn't get down to the alveoli, it does not have a chance to make that exchange with carbon dioxide. Okay? The ventilatory rate that is too slow will not provide enough air in the alveoli for adequate gas exchange either. A ventilatory rate that is too fast can cause two problems. Problem number one, the rate is so fast that it doesn't allow the lungs adequate time to fill between breaths, which reduces the tidal volume. Problem number two, a fast rate requires a large amount of energy and muscular workload that may not be sustained, which is going to set the patient up for respiratory failure. Ventilatory rates of 40 minutes or greater in the adult patient and greater than 60 minutes in the pediatric patient are too fast to be sustained or allow adequate time for a normal tidal volume. All right. Generally speaking, whenever an illness or injury affects the lungs, it typically causes a change in the tidal volume, in which a reflexive increase in the respiratory rate. For example, severe pneumonia can cause the alveoli to become plugged with pus or mucus. This reduces tidal volume and hypoxia results. A pneumothorax or a collapsed lung, and it makes it difficult for the alveoli to inflate. This is a drop in tidal volume as well. If a patient has a flail segment, all right, what is a flail segment? Anybody know? It's when two or more ribs are broken in two or more places, all right? You get a seesaw action with the chest. You have one part that comes up while the other part falls down. It's called, I'll think about it in a minute. If they have the flail segment, the bellowing action, that one side comes up, other side goes down, you're not getting enough air in. Those lungs aren't expanding enough for you to get air in. All right, this causes a drop in alveolar ventilation and tidal volume as well. Breathing is mostly an involuntary process that is controlled by the autonomic nervous system to maintain normal gas exchange. Receptors within the body constantly measure the amount of oxygen, carbon dioxide, and hydrogen ions, which is your pH balance, and send signals to the brain to adjust the rate and depth of respiration. You do have some voluntary control over your breathing that allows you to hold your breath or alter your breathing pattern during talking, laughing, or singing. But primarily, involuntary control is through the respiratory center located in the brainstem, which sends out sensory impulses to the respiratory muscles. The central chemoreceptors are located near the respiratory center in the medulla. These receptors are most sensitive to carbon dioxide and changes in the pH of the cerebrospinal fluid, or CSF. The pH is a measurement of hydrogen ion concentration. Okay, you can either be basic or acidic, okay? Alkalinic or acidic. The peripheral chemoreceptors are located in the aortic arch of the carotid bodies in the neck. These chemoreceptors are also somewhat sensitive to carbon dioxide and your pH, but are most sensitive to the levels of oxygen in the arterial blood. As the level of oxygen in the blood decreases, the peripheral chemoreceptors send signals to the respiratory center in the brainstem to increase the rate and depth of respiration. All right, so we're going to touch very, very shortly on this hypercapnic drive. All right, hypercapnic drive is in control of breathing regulated by the level of carbon dioxide in the blood, which is normal. Then you have a hypoxic drive. It's the control of breathing regulated by the level of oxygen in the blood due to the failure of the central chemoreceptors. Okay, hypercapnic drive is normal, hypoxic drive is abnormal. Okay, you're going to see this hypoxic drive with like your COPD patients. Okay, they normally have a low O2 sat. That is their normal. They can live like that. Their body is accustomed to that. If you go in and slap on a non-rebreather on these COPD patients, they're going to lose that hypoxic drive because they have too much oxygen. Okay? And they're going to go into respiratory failure. All right? All right. Like we talked about, COPD patients have a tendency to retain carbon dioxide. All right, this is your emphysema. Emphysema tends to retain carbon dioxide in arterial blood as a result of lung disease caused by poor gas exchange. When the arterial carbon dioxide level is chronically elevated, the central chemoreceptors become insensitive to the small changes that typically stimulate ventilations. The peripheral chemoreceptors then become the primary stimulus for ventilation instead of the small increase in carbon dioxide levels being a strong stimulus for ventilation. The peripheral chemoreceptors rely on a decrease in the oxygen level to stimulate ventilation. Hypoxia becomes the stimulus for ventilation in a place of hypercarbia, and this is also known as your hypoxic drive. All right, you have some other receptors in the lungs. You have irritant receptors. These are found in your airways. It's sensitive to irritating gases, aerosols, and particles. It stimulates coughing, bronchoconstriction, and increased ventilatory rate. You have stretch receptors that are found in smooth muscle of the airway, and it protects the lungs against overinflation. Then you have what's called J receptors. These are found in the capillaries that surround the alveoli. They are sensitive to increase in capillary blood volume. When activated, they stimulate rapid, slow ventilations. All right, there are 3 respiratory control centers in the brain: the dorsal respiratory group, the ventral respiratory group, and the pontine respiratory center. The ventral respiratory group and the dorsal group are located in the medulla oblongata. I just like saying that. The pontine, also referred to as the pneumotaxic center, is located in the pons of the brainstem. These centers have sensory input and transmit impulses to the skeletal muscles controlling ventilation, causing them to either contract or relax depending on the impulse. All right, your ventral group, located in the medulla, receives sensory input and sends it to the spinal cord to stimulate the diaphragm and intercostal muscles. It contains inspiratory and expiratory neurons, and it controls your basic pattern of breathing. Dorsal group is located in the medulla as well, receives sensory input and communicates it to the ventral group for further input on rate and depth of breathing. Then you have your pontine group, sends inhibitory impulses to the inspiratory neurons of the ventral group to turn off inhalation, or it promotes smooth muscle relaxation between inhalation and exhalation. All right, the patient is working hard to breathe, has pale, moist skin. He's not sounding real good right now, is he? He is using accessory muscles to breathe, but seems to be moving very little air. Man, the more we read, the worse it gets. The patient appears sleepy, as if on the verge of exhaustion. All right, Patty selects a bag valve device or mask to assist the patient's ventilation and connects it to supplemental oxygen. So, what kind of medical problem could lead to a patient having such severe difficulty breathing?
Chronic bronchitis.
Okay. Asthma. What'd you say? Pneumonia. COPD, CHF.
TB.
Pulmonary embolism.
Yep, pulmonary embolism, TB. The COVID. Lots of things, okay? All right. Ventilation perfusion ratio describes the dynamic relationship between the amount of ventilation the alveoli receive and the amount of perfusion through the capillaries surrounding the alveoli. This relationship determines the quality of gas exchange across the alveolar capillary membranes, which influences the amount of oxygen entering the blood and the amount of carbon dioxide exiting the blood. This relationship between ventilation and perfusion in the lungs can be used to explain the etiology or the cause of hypoxemia or inadequate oxygen concentrations in the blood. All right. In the ideal lung, each alveoli would receive an adequate amount of ventilation and a matching amount of blood flow through the surrounding capillaries, resulting in a ventilation perfusion ratio that is equal. This ideal condition never exists because of the effects of gravity on blood, the structure of the lungs, and shunting of blood. With an individual in the standing position, gravity pulls the lungs downward towards the diaphragm, compressing the lower lobes. As the lower lobes are compressed and the blood is pulled down to the base of the lungs, air travels upward to the apexes or the top of the lungs, and it increases the residual volume. The alveoli and the apexes of the lungs have a greater residual volume of air. They're larger and have a higher surface tension, but they are fewer in numbers compared to other areas of the lungs. These larger alveoli have a higher surface tension, which makes it less compliant and harder to inflate during ventilation. So, the tidal volume is shifted to the lower lobes where the lung is more compliant and there is less surface tension because gravity pulls the blood downward. Less pressure is required to perfuse the lower lobes. The bases of the lungs receive greater amounts of blood and are much better perfused than the top. This is a desirable condition because the greatest amount of ventilation also exists at the base of the lungs. This ratio is never at an ideal state in any zone of the lungs. In the apexes, we talked about that. It's a little bit better in the bases, all right? In the bases, the amount of perfusion exceeds the amount of ventilation. This means more blood moves through the pulmonary capillaries than there is alveolar oxygen available to pick it up. This is called wasted perfusion. Overall, under normal circumstances, perfusion exceeds the amount of available ventilation. So, looking at this right here, what do you think could be some causes of ventilation mismatch here?
Blood clot.
Blood clot. Okay. What if you have fluid in here? Is that air gonna be able to move out? Okay. What if they're not getting the blood all the way down to, getting the oxygen all the way down to the alveoli where the oxygen exchange actually takes place? They're not breathing deep enough So that oxygen's not gonna make it down there, right? Alright, the perfusion of blood through the pulmonary capillaries is affected by the amount of air and pressure inside the alveoli and the pressure of blood flowing through the capillary beds. If the pressure in the alveoli exceeds the blood pressure in the capillary beds, blood flow through the capillary stops. This is most likely going to occur at the top of the lungs, okay, the apexes. It can also occur in a patient who's lost blood from an injury and has a decreasing blood pressure. Why would you see this with somebody having a decreasing blood pressure?
Because their blood's not going where it needs to go.
Because their blood's not going where it needs to go. All right. All right, a disturbance on the ventilation side can lead to hypoxia. If a condition or injury causes less oxygenated air to be available in the alveoli, with the amount of blood flowing through the pulmonary capillaries, the end result is going to be less oxygen saturation in the blood and less oxygen delivered to the cells, creating hypoxemia and cellular hypoxia. All right, what would you think would maybe cause this? Decreases the amount of air reaching. Okay, maybe we're not able to get air in. We're not able to get air in. It'd be
Clogged airway.
clogged airway. Okay. That also kind of be known as what? What causes constriction and mucus production? Asthma. Management goals should be aimed towards improving alveolar ventilation, be that by relieving bronchoconstriction, airway occlusion, or supplementing ventilation in the patient with respiratory failure. That bronchoconstriction that I talked about, that's going to be your asthma. A perfusion disturbance can also lead to severe cellular hypoxia. If a patient has lost a substantial amount of blood, or if the right ventricle is unable to adequately perfuse the lungs, then it will create a situation of wasted ventilation. Although the use of oxygen may improve the situation, the fundamental flaw and the problem is a perfusion deficit. Okay? We're getting the air down in there, we just don't have anything to make we don't have enough oxygen to put it in the bloodstream. Or we don't have enough oxygen, blood, to uptake the oxygen. Oxygen must be continuously delivered by the blood to the cells for normal cellular metabolism to occur. Carbon dioxide, which is a byproduct of aerobic metabolism, must be carried back to the lungs and blown off in exhalation. A disturbance in the transport system may lead to both cellular hypoxia and a lack of oxygen available to the cells and lead to hypercarbia. This means too much carbon dioxide. Both hypoxia and hypercarbia pose problems for normal cellular function and stability. All right? You can have too much of a good thing and you can have too much of a bad thing. All right? Both oxygen and carbon dioxide are transported by blood, but in different ways. It's important to remember that oxygen and carbon dioxide move from areas of higher concentration to areas of lower concentration. This helps explain the movement of gas molecules between the alveoli and capillaries, and between the capillaries and the alveoli. Approximately 1,000 milliliters of oxygen is delivered to the cells every minute. Oxygen is transported by the blood in two ways. It's dissolved in plasma, and it's also attached to the hemoglobin. Only a small amount, about 1.5 to 3%, is actually dissolved in the plasma. Most of it, 97 to 98.5, is attached to your hemoglobin molecule. Hemoglobin is a protein molecule that has 4 iron sites for oxygen to bind to. Thus, one hemoglobin molecule can carry up to 4 oxygen molecules. Once an oxygen molecule binds with hemoglobin, it is referred to as oxyhemoglobin. A hemoglobin molecule that has no oxygen attached is referred to as deoxygenated hemoglobin. Deoxyhemoglobin. Without hemoglobin, the amount of oxygen that can be transported by plasma would not be enough to sustain normal cellular function or life. So, a loss of hemoglobin, which commonly occurs as a result of what? How do we lose hemoglobin? Bleeding. Okay? Being anemic. Alright. It's not really, anemia is not really the hemoglobin, it's the iron that binds to that allows the oxygen to bind to the hemoglobin, if that makes sense. Alright. A loss of the hemoglobin, which commonly occurs as a result of bleeding, can lead to severe cellular hypoxia, even though an adequate amount of oxygen is available. Carbon dioxide is transported in the blood in 3 ways. Approximately 7% is dissolved in plasma, 23% is attached to hemoglobin, and 70% is in the form of bicarbonate, or bicarb. The largest amount of carbon dioxide diffuses from the cell into the blood, then into the red blood cell. In the red blood cell, carbon dioxide combines with water to form carbonic acid, which then dissociates into hydrogen and bicarbonate. Bicarbonate exits the red blood cell and is transported in plasma. When blood reaches the lungs, bicarbonate diffuses back into the red blood cell where it combines with hydrogen and then dissociates into water and carbon dioxide. Carbon dioxide diffuses from the blood through the alveoli and is released through exhalation. Alright, so we talked about gas molecules move from an area of what concentration to what concentration? High to low. Alright, so venous blood carries what kind of blood? Is it oxygenated or deoxygenated? Deoxygenated. And arteries carry what kind of blood? Oxygenated. Alright, one of the determinants of an adequate blood pressure and perfusion is blood volume. An adult has approximately 70 milliliters of blood for every kilogram. How much is a kilogram? 2.2 pounds. Okay, 1 kilogram is 2.2 pounds. You need to know that. You need to know how to convert kilograms to pounds and pounds to kilograms. A patient who weighs 154 pounds, how many kilograms would they be? Pull your phones out, divide it. $154 divided by 2.2. 70 kilos. Alright? They would have an approximate volume of 4,900 milliliters, or 4.9 liters of blood. Blood volume correlates with body mass. Therefore, a larger patient would normally have a greater blood volume. So, if I get cut in two, I got a better chance than all you. Alright, the loss of 1 liter of blood in a 100-pound patient would be much more significant than in a 200-pound patient. Alright, think about that when it comes to kids. Okay, they don't have as much blood as what we have. Their bodies are smaller. So even just a little bit of blood loss for them is going to make a big difference. Okay, blood is composed of formed elements and plasma. The formed elements, which are cells, make up approximately 45% of blood composition. Plasma is the fluid component that accounts for the remaining 55%. Plasma is made up primarily of water and plasma proteins. Water comprises 91% of plasma. The plasma proteins consist of albumin, antibodies, and clotting factors. The formed elements in blood are red blood cells, white blood cells, and platelets. All right? What do your platelets do? It's what clots your blood. Okay? What do your white blood cells do? Fights infection. What do your red blood cells do? Carries oxygen. Fantastic. Alright. So, white blood cells, normally they're called leukocytes. There's several different kinds, but we're going to talk about leukocytes. Alright, protects the body against infection and eliminates dead and injured cells or other debris. The platelets, they're called thrombocytes, are not actually cells, but fragments that play a major role in blood clotting and the control of bleeding. What is a hereditary condition that causes uncontrolled bleeding? What? Hemophilia. Okay? They cannot clot. And the funny thing is, they give them the antidote for rat poisons. Anybody know what that is? Rat poison's like giving somebody blood thinners. Alright? It's like taking a whole... Anybody know what Coumadin is? It's a blood thinner. Okay? Alright, it's like, if you eat rat poison, it's like taking a whole bottle of Coumadin. You're going to bleed from every opening you have, plus some. Okay? The antidote for that, and the antidote for hemophilia, is vitamin K. It's also what they give dogs when they eat rat poisoning. Just FYI. Alright, blood is distributed through the cardiovascular system. The majority of blood is housed within the venous system, which is known as the reservoir. The venous system can enlarge or reduce its capacity to respond to increase or decrease in the blood volume. The venous system is responsible for supplying the right side of the heart with adequate blood volume. If the volume entering the right side of the heart is decreased, the amount ejected from the left ventricle through the arteries is also going to be decreased. Okay? Thus, the venous system plays a major role in maintaining blood pressure and adequate perfusion of the cells. Hydrostatic pressure is the force inside the vessel or capillary bed generated by the concentration of the contraction of the heart and the blood pressure. Hydrostatic pressure exerts a push inside the vessel or capillary. It wants to push fluid out of the vessel or capillary through the vessel wall and into the interstitial space. A high hydrostatic pressure would force more fluid out of the vessel or capillary and promote edema. Okay, this is why you see the leg swelling. All right,